Are you ready to advance your career in one of the most dynamic and impactful fields in healthcare? Welcome to the Cardiac Critical Care Fellowship, an entirely online program designed to fit your busy schedule, offering 3 comprehensive modules, each worth 30 credits. Learn from world-class clinicians and gain access to evidence-based content, cutting-edge research, and real-world case discussions in cardiac critical care. This program is tailored for self-driven learners who want to take control of their education and unlock their potential. Whether you're managing critically ill cardiac patients or looking to master ECMO, mechanical circulatory support, or perioperative care, this fellowship will empower you to excel. With flexible, interactive, case-based learning, you'll gain the skills needed to advance in this high-stakes field, all while earning certification to boost your career. Join us today and start your journey towards becoming a leader in cardiac critical care. Are you ready to make a difference?
Welcome to our final webinar on the Cardiac Critical Care Program 2026. My name is Ashwag Mahdali. I am blessed to be your host today. We are honored to be joined by Dr. Hatem Sulaiman, Senior Educator at King College London and Cardiac Critical Care and ECMO Consultant at Herfield Hospital. He will share his expertise and insight on evolving role of ECMO in cardiac surgical patients, especially those on mechanical circulatory support. Thank you all for joining us today. We hope you find the session both informative and engaging. Please note that this webinar is being recorded and will be available in our YouTube channel. The session approximately 45 to 60 minutes, including the question. So feel free to submit your question through the Q&A box at any time. Just summary about the program. So the Cardiac Critical Care Program is a program that have 3 modules, each module almost 16 weeks, including the exam for each module. It's self-paced learning, including lecture, MCQ testing for the lecture knowledge with explanation, case scenario, and peer-reviewed publication. So 3 modules, including module 1, which is the foundation of cardiac critical care, physiology, hemodynamic, including the basic echo and advanced echo, as well as PCU management. The second module, it's including basic intraoperative and post-operative care, including the cardiac anesthesia, basic cardiac surgery, and post-op complication. While the third module, it's including the mechanical circulatory support, including ECMO, intra-aortic balloon pump, impella, and ventricular assist device. So upon completing of the program, you will be expected to receive an American Accreditation Association certificate, CME hours, knowledge of how to deal and troubleshooting of the mechanical circulatory support, mastering the management of cardiac critical care patient. So this is our website. We usually have a question of MCQ and some case scenario with discussion. And you can join through the barcode. And any question, feel free to reach us through our website. I will give the mic to Dr. Hatem to start his lecture. Thank you so much for joining us again.
Assalamu alaikum. Thank you very much, Dr. Ashwaq, for inviting me. And congratulations to you and the chairs of this very nice educational initiative and very important educational initiative. My lecture will cover the use of echo in short-term mechanical circulatory support. For the sake of time, I chose to highlight only the short term because long term is quite different in management, but I will cover the broad spectrum of short term devices, starting from balloon pump, impella, and ECMO. And I'm going to share my slides now. Can you see my screen?
Yes.
Okay, so we will talk about echo, not only echocardiography, I would even call it echography, because now echo extends beyond the heart. We use multi-organ assessment with ultrasound. I have no disclosures in relation to this talk. When I talk about ECMO and short-term devices and short-term mechanical circulatory support devices, I always remember the Murphy's Law. Some of you might already know what the Murphy's Law is. Uh, Murphy's Law is a law which is telling us that what can go wrong will definitely go wrong at the worst possible time. So this is a reminder for us to be proactive and not reactive. This is really important when managing patients with short-term mechanical circulatory support with cardiogenic shock, because being proactive will enable you to anticipate trouble and to troubleshoot before the patient gets worse. And that is why echo is very useful in this context. I will start with a case to highlight what I want to discuss. This was a 55 years old gentleman who was transferred to us from another institution with manifestations of low cardiac output. Although he was warm on the edges, he was not cold. Clearly had worsening lactate, worsening base deficit. He was febrile. Inflammatory markers were raised. He was hypoxic, hypotensive, and the troponin was only mildly elevated. And if you look here at the echo, this is the initial basic focused transthoracic echo, parasternal window, you will clearly see that the contractility is reduced. Biventricular contractility is visually impaired. Before I leave the slide, I want to highlight something. This patient has clear evidence of low cardiac output. Although the patient was not cold, the patient was warm. And this explains the paradigm shift in our understanding of cardiogenic shock. Cardiogenic shock is not anymore exclusively the cold and wet phenotype, because some patients with cardiogenic shock might present with reduced systemic vascular resistance, being inflamed. And this is actually the worst phenotype, because patients with cardiogenic shock who are warm and wet have higher mortality. And this is what the latest registries and studies showed us. And this was an example. But now let's carry on with our case. And I was telling you that this is an example of reduced biventricular contractility and clinical features of shock. We don't diagnose shock by echo, we diagnose it clinically, but we use echo to identify the type of shock. So what I want to say here is contractility should not be utilized to assess shock because it can be misleading. And the famous parameter, the popular parameter in contractility is the ejection fraction. Ejection fraction is not validated in shock, and it should not be used in critically ill patients because it can be easily overestimated or underestimated. And ejection fraction itself is a parameter which was validated in outpatient settings where they have predictable and stable preload and afterload, while this is always changing in acute hemodynamic instability and critically ill patients. So you have here two examples, two different patients where ejection fraction was completely misleading. This is obviously a transesophageal echo. So you have on your left-hand side, you have the left ventricle, which seems to have preserved contractility. I will try to use the pointer here. So you can see here the laser pointer. This is the left ventricle, which seems to have preserved contractility, but this patient had a full-blown cardiogenic shock. And why the patient had cardiogenic shock? Because number one, you could see that the mitral valve had lots of turbulence. This is acute severe mitral regurgitation because of the flail posterior mitral leaflet, and also because the right ventricle was poor. So right ventricular impairment contributed to the underfilling and the appearance of an empty left ventricle, and also the mitral regurg, the acute mitral regurg, reduced the afterload of the LV, causing the appearance of an empty LV. And that's why ejection fraction here was completely misleading. While if you turn your eye and look into the right-hand side, you see a completely different scenario. You see a patient with very severely reduced contractility. The LV is severely impaired by contractility, but this patient had very stable hemodynamics and stable cardiac output. So the key message here, don't use ejection fraction to assess shock in critically ill patients. What should we use instead? I think we should use Doppler because it is widely available, it is validated. Pulsed wave Doppler assessment and estimation of stroke volume by putting the pulsed wave sample volume at the LVOT, the left ventricular outflow tract, will enable you to trace the flow across the LVOT. And this was a machine which had an AI automation. So this is an auto VTI. Some machines have auto VTI. I personally prefer the manual estimation of the VTI because it's more reliable. We have not reached a degree of maturity for automated VTIs to follow them completely. But anyway, this patient had a clearly reduced VTI. The VTI is velocity time integral. So it's not a velocity, it's an integral. Integral mean distance. So the unit of VTI is centimeters. And it is basically the distance the blood travels across the LVOT in a heartbeat. And here you could see that the VTI was about 8.2 centimeters, which is significantly impaired. And the normal VTI should be between 18 to 22 centimeters in this range. And this is indicative of profound reduction of cardiac output, profound reduction of perfusion. And the equation of stroke volume by echo is not only determined by VTI, but also determined by the area of the LVOT. So if you want to calculate stroke volume, you need to obtain the VTI, which is the distance of that cylinder, assuming that the LVOT is a cylinder. So if you know the height of the cylinder, which is the VTI, and the area of the cylinder, you multiply the area by the height, which is the VTI, it gives you the volume of the cylinder. And then you multiply by heart rate, it will give you cardiac output. Then you divide by body surface area, it gives you the cardiac index. This is an extremely useful number for us in critically ill patients, particularly when you assess shock and perfusion, the cardiac index. And this is completely done non-invasively using echo. So now we have reached an agreement that this patient is in big trouble. Patient has low cardiac output. But before we leave the VTI, we want to highlight some pitfalls of the VTI, particularly certain scenarios where the VTI will not be reliable, especially if you have acceleration across the VTI, if you have obstruction, the VTI will be overestimated. This is something that you can see frequently in critically ill patients, by the way. This is not rare. This is frequently seen, particularly in sepsis, in hypovolemia, patients on inotropes, particularly if you have mitral valve surgery, abnormal anatomy of the mitral leaflet, particularly if you have a basal septal hypertrophy. All these situations predispose the patient to dynamic obstruction of outflow. And this is all common in ICU context. So when you encounter patient with shock, before jumping into the conclusion that they have cardiogenic or hypovolemic shock, you must put Doppler at the outflow and look for any dynamic acceleration, because this is a distinctive phenotype of shock. How does it look like? You could first look with 2D echo. This is a apical four-chamber view, and this is the famous and popular SAM, systolic anterior motion of the mitral leaflet. If you look here with me on the mitral leaflets, you will notice that the anterior mitral leaflet is bending and bowing towards the septum rather than coapting completely with the posterior mitral leaflet. So normally both leaflets should coapt smoothly like this. But in this case, the anterior leaflet loses coaptation and bends toward the septum. And this creates obstruction to outflow because it basically occludes outflow. And this will cause the late peaking with continuous wave Doppler, which is typical of obstruction, dynamic obstruction of outflow. And if you encounter this phenotype of shock, the management will change completely, because usually if it's cardiogenic shock, you would like to give inotropes, you would like to stop fluids and maybe remove fluids if the patient blood pressure will tolerate. You might require to increase heart rate, but any of these measures will worsen obstructive shock if it is due to dynamic obstruction. So when you encounter this phenotype, you will need to give fluids, you will need to stop inotropes, you will need to reduce heart rate, whether by pacing or beta blockers. So I always argue that this is a pathophysiology that's impossible to diagnose without echo. Tell me about any clinical or imaging modality which can detect this pathophysiological problem. It's impossible without echo. So here, echo is life-saving, undoubtedly. And if you don't detect this obstruction earlier on, you might lose your patient by increasing the inotropes. But before I leave that, I also want to highlight that LV obstruction sometimes does not happen in isolation. Sometimes it happens in the context of RV failure. And this is what's happening here. This is a short axis view. This is a transesophageal echo, transgastric short axis view at 0 degrees. And here, clearly, the LV is obstructed with kissing papillary muscles, and the RV is severely impaired. And this is a nightmare. When I see this scenario in our perioperative settings, this is clearly a nightmare, because if you stop inotropes to relieve obstruction of the left side, the RV will get worse because the RV will require some inotropes. So when I encounter this combination between an RV failure and obstructed LV, echo is not enough. You will need continuous hemodynamic monitoring, whether by PICO, whether by pulmonary artery catheter Swangans, to carefully titrate inotropes. You cannot simply stop them. You might need to reduce them. Start afterload increase by vasopressors, which do not have inotropic effect. Maybe start inhaled nitric oxide or pulmonary vasodilators to offload the RV. But this is a very, very tricky scenario. And it reminds us of the very important physiological principle of interventricular dependence. The LV does not function alone. Always interpret LV function in the context of RV function. And this is one of the foundations of cardiovascular physiology, particularly when using echo. Also, I'm still with VTI. The VTI itself, although it's a very useful number, but it is just a number. There are certain scenarios where the VTI can be normal, but the patient is abnormal. Sepsis, for example, you expect much higher VTI than 20. Severe aortic regurg, you expect much higher VTI than 20, etc. And finally, this is a bit more advanced, but it's a parameter that can be used by echo to determine the chamber limiting cardiac output. Because one of the issues with VTI or LVOT VTI is that it is not specific to the left heart. Although it is called left ventricular outflow tract VTI, but it can be reduced from isolated left ventricular failure or isolated right ventricular failure or biventricular failure. And if I want to assess mechanical circulatory support, and this is what I'm going to discuss shortly, and I wanted to discuss a bit about shock before starting MCS. I wanted to show you that this parameter, particularly the TIVT, can be used to specifically identify the chamber limiting cardiac output. And we have now a validated parameter and validated cutoff, less than 12 seconds per minute. This is the normal TIVT. The TIVT is simply the combination of isovolumetric contraction and isovolumetric relaxation. I'm not going to discuss it in depth, but just remember that there is a parameter which can tell you the chamber limiting cardiac output. And if you are not sure the right or left heart is the problem, do the TIVT on the left. And if it's normal, then I'm sure the problem is on the right heart. I will now jump quickly into the MCS part. So this is a review we published last year, which is open access. It was a transatlantic initiative to discuss the breadth of short-term mechanical circulatory support devices assessment by echocardiography. And it has a lot more details than what I'm going to discuss in this lecture. So I will start with the balloon pump, which is the oldest known mechanical circulatory support devices. But actually, it's not a pump. It's named a pump, but it does not pump blood. It is just an assist device. It's a passive balloon. It works, as you know, by inflating in diastole, increasing coronary perfusion, and deflating in systole, reducing afterload. It has been used since 1967, and it provides minimal support to perfusion, only 0.5 to 1 liter. In reality, it's only about 0.5 liters. In some experimental animal studies, it can reach up to 1 liter of cardiac output. So it's a minimal increase in cardiac output and no mortality benefit in randomized control trials. And the best evidence we had so far for use of balloon pump is after mechanical complications of myocardial infarction. However, I always say that we should not discourage our colleagues from using balloon pumps because in many centers around the world, it might be the only device available. And certainly using balloon pump is better than not using anything. In a patient who is crashing in cardiogenic shock, Intermax 1, if you have a balloon pump, you have to know how to use it because it will enable you to temporize the patient until you transfer the patient to a specialist center. And using echo is fundamental because it enables you to position the balloon pump, particularly the upper tip, which should be located distal to the left subclavian artery. And this is the key thing about balloon pump positioning. An echo is superior to fluoroscopy, and I'm particularly talking about transesophageal echo because it can be used at the bedside. You can insert the balloon pump in the ICU without needing to move the patient to the cath lab. It's free from ionizing radiation. Also, echo itself can help you assess the indications, the contraindications for a balloon pump. You can monitor the insertion in real time, identify the complications in real time, and even assess the efficacy. And this is a summary of the indications and contraindications of putting balloon pump. I will leave it to you to read it later. And when you use echo for inserting balloon pump, you should have a structure, a sequence. You start with a comprehensive TOE, that's important. And then later on, you focus on the aortic valve and the thoracic aorta. And as I said earlier, the key thing is to position the upper tip of the balloon pump, the proximal tip, distal to the left subclavian artery. Here on transesophageal echo, you could see the guide wire inserted through the descending aorta. This is the descending aorta long axis at 90 degrees, and then followed by the catheter or the balloon pump itself. And here, this is a technique we use perioperatively in theater and ICU to position the tip of the balloon pump. What happens here is it starts by identifying the tip of the balloon pump in the descending aorta short axis view. And then you put both your index and thumb finger, both index and thumb finger, as you could see here in the video, on the TOE probe where you identified the tip of the balloon. And then you start withdrawing the TOE probe. So you'd withdraw the probe until you see the left subclavian artery. And then the distance between your fingers and where you saw the left subclavian artery is the distance between the tip of the balloon and the left subclavian artery. And that's how you adjust it. So if it is at the same distance, you have to withdraw the balloon pump. You have to withdraw the probe a little bit more to keep that 2 or 3 centimeter distance between the upper tip of the balloon and the left subclavian artery. And this is a very easy technique. You can even practice it on a simulator before you do it on patients. And then another very important thing to highlight is post-insertion checklist. Once the balloon pump is in, you have to look for any complications, whether aortic injury. You can even assess the efficacy of the balloon pump by measuring the LV dimensions, the degree of mitral regurg, the LVOT-VTI, and even you can do some fancy stuff by assessing the coronary blood flow by Doppler, by using color or pulse wave Doppler, because if the balloon pump is augmenting effectively, you should see diastolic increase in velocity when the balloon inflates. And finally, I think this is one of the most important slides in the balloon pump section, which is the caveats. Remember that the balloon pump itself works by reducing afterload. So you should be very cautious and you should try to avoid inserting the balloon pump in patients with reduced afterload. For example, sepsis, vasoplegia, moderate to severe aortic regurg. Even with mild aortic regurg, you can insert the balloon pump, but keep in mind that it will be less effective. And finally, remember, we talked about dynamic obstruction. Patients with dynamic obstruction, they need higher afterload because the higher afterload will increase the end systolic volume of the LV and reduces the obstruction. Imagine if you put a balloon pump for a patient with dynamic obstruction and SAM, they might get worse and deteriorate. So keep this in mind when you see a patient who requires a balloon pump. The next device that I'm going to discuss is the Impella. Impella is it's a proper pump, so it's a true pump, and it's a more novel device. It's obviously much more expensive, and there are different modalities or different models of Impella. Currently, there are mainly left-sided impellers now in the market. Right-sided impellers are not in the market at the moment. They are suspended because they are developing the technology, but the left-sided impellers are widely available. And the danger shock study is the latest and the only positive RCT in mechanical circulatory support devices. And it exactly showed the role of the Impella to CP in patients after STEMI. So Impella is there. Of course, it is not widely available because of the cost, but in many specialist centers in the Middle East or Europe or America or Australia, Impella is used. And we use a lot of Impella in our institution, and it provides a powerful augmentation of flow. So this small pump is so powerful. There is the Impella CP, which can give 3.5 liters of flow, and the Impella 5.5, which can give 5.5 liters of flow, which is full circulatory support. And you could see here in that schematic how the Impella looks like. So Impella here is inserted via the femoral artery. This is the percutaneous approach for the Impella CP, the smaller Impella. And you have this going all the way through the arch, crossing the aortic valve and sitting inside the LV cavity. And here you have an inflow and an outflow. The inflow will constantly aspirate or suck blood from the LV, and the outflow will constantly eject blood into the ascending aorta. So the Impella has a double effect: constant offloading of the LV and constant augmentation of perfusion in the ascending aorta. And here I show an example of using one of the less utilized echo techniques in deciding putting an Impella or not. This was a patient who had anterior STEMI. He was a young patient and clearly had univentricular failure. This is clearly a left ventricular failure. He was worsening on inotropes, on two inotropes, crashing and burning, and needed support. So we were wondering whether we put an Impella or ECMO. But there is a problem here. There was a shadow in the apex. You could see with me here, there's a questionable shadow in the apex, which could be a thrombus. And if this was a thrombus, Impella is contraindicated. So what we did, we used contrast, bedside contrast, sonoview, immediately showed full opacification of the ventricle, ruled out a thrombus, and the patient had an Impella successfully. And it was a bridge to recovery. Patient had it for about 10 to 11 days. Luckily, he did not require longer term devices or transplant. And this is a good example of using contrast at the point of care. This was not a full contrast study like the ones done in the outpatient clinic, but this was a point of care contrast to rule out apical thrombus. This is the Impella console. For those of you who have not seen it, you could see here the placement signal, which shows the position of the Impella, whether it's in the aorta or in the LV. You have the motor current. This is the amount of flow provided, how many liters. And this is the P level, which is the level of P is pressure, so the amount of pressure or sucking by the motor of the impeller. The higher the P, the higher the output, and the higher the speed of the motor. And one of the main uses of echo here is determining the position of the impeller and the anatomy of the impeller device. You could see it here. This is mid-esophageal long axis view. You could see the impeller, which appears like a railroad going across the aortic valve. You have here the teardrop, which is the inflow, and then you have the pigtail. The pigtail is present in the smaller impeller, the CP, to protect the LV wall from the tip of the impeller. And normally, the inflow should be positioned about 3.5 to 4.5 centimeters from the aortic valve. And if it's an impeller 5.5, which is the bigger impeller, it does not have a pigtail. So the impeller is allowed to go more deeply between 4.5 to 5.5. So remember, the CP is up to 4.5 and the 5.5 is up to 5.5 centimeters from the aortic valve. And in our latest document, we also showed one interesting sign, which is the crush pigtail sign. The crush pigtail is a sign predictive of malrotation of the impeller, which is also predictive of hemolysis, suction events, acute kidney injury, and outcome. And you could see here at the top, this was a properly positioned, the green panel, the properly positioned impeller, the correlation between echo in the circle and the X-ray or fluoroscopy. And you could see on the left that the alignment of the axis of the body of the impeller, which is the dotted or the dashed white line, with the pigtail, which is the yellow dashed line. This alignment predicted that the inflow will be in the middle of the cavity, which is good position. While here, if you notice that the pigtail is twisted and there is an angle between the pigtail and the body of the impeller, that will predict that the inflow will be sucking or attached or close to the posterior wall, which will predict hemolysis, suction events. And this is the crush pigtail sign. And it just tells you that you could see by X-ray or fluoroscopy what you would see on echo and vice versa. Because the impeller is an LVAD, it's a left ventricular assist device, so it relies on a preserved or a stable right ventricular function. And in this case, the RV was poor, it was dilated, so the patient had suction events. The impeller was sucking on the LV because the RV preload was impaired. It was not providing adequate preload to the LV, and this was a problem which required inotropes. In this case, you needed inotropes, you have to stop giving fluids, and you might also want to give pulmonary vasodilators if the patient was intubated. And this is another pitfall of the impeller, where the impeller itself was pushing on the anterior mitral leaflet, causing significant mitral regurg and pulmonary edema on lung ultrasound. And finally, because impeller is a device which is often inserted peripherally via the groin, you have to check with Doppler the lower limb perfusion routinely and on a daily basis, which is really important in these patients because the instance of leg ischemia can be high, particularly in elderly and patients with vasculopathy. I will now move to the last part of the lecture, which is ECMO. ECMO is simply a modification of cardiopulmonary bypass. So ECMO allowed us to move bypass from the operating theater to the bedside and even to the streets, because now ECMO is done as part of ECPR in the train stations. We had an ECPR in our canteen a few months ago. So this is a cardiopulmonary bypass, but outside the operating theater. And ECMO has four main components. It has a pump, it has an oxygenator, cannulae, and tubing. And there are different types of ECMO, mainly VV ECMO or VA ECMO. As you know, VV ECMO is particularly the respiratory ECMO, where you drain from the right side of the heart and then retain the oxygenated blood also to the right side, while VA ECMO is returning the blood to the left side of the heart. And that provides full cardiorespiratory support and bypasses the function of the right heart, bypasses the function of the left heart. But one thing to keep in mind is that ECMO itself, or VA ECMO, can be peripheral, can be central. The peripheral will include a return cannula in the femoral artery, which means that you are returning blood against the natural downstream of blood in the descending aorta, which will increase LV afterload in most of the situations. But central ECMO will be more likely or mostly perioperatively after cardiac surgery or during cardiac surgery, where the return cannula is directly inserted via a graft in the ascending aorta, which is more physiological but more invasive. So this is a simulation which is showing the impact of peripheral V ECMO on the volumes. You could see on these PV loops that the volumes increased, the pressures increased, and the native stroke volume is smaller, which is the area of this PV loop. But this is not the case actually. This is what we learned recently, that it is not necessary that after peripheral V ECMO that the LV distension will happen, because the impact of peripheral V ECMO on LV pressures is not only determined by increasing afterload, but also determined by the impact on preload. Remember, the ECMO includes draining from the right heart and returning to the left. So some patients develops improvement in left ventricular end diastolic pressure after peripheral V ECMO. So not every patient on peripheral V ECMO will have LV overdistension and all the complications, as we previously thought. But echo is fundamental throughout the decision-making pathway for peripheral V ECMO, from the diagnosis to choice of modality to guiding cannulation, daily echo and lung ultrasound, troubleshooting, weaning, and even follow-up after decannulation. And I'm just jumping for the sake of time, just to show you the highlights. So this is here the position of the VV ECMO cannula, the drainage cannula in the IVC, and the return cannula in the SVC right atrial junction. And this is another view, which is the transhepatic mid-axillary view, where you could see the IVC and the aorta in the same view, which can help you during ECPR by seeing the positions of the guide wires. And this is a complication which happens from the cannula, the drainage cannula infiltrating the intraatrial septum, creating an interatrial shunt. You could see here a clear left to right shunt, and this was a big issue, required a closure with a closure device. And with VV ECMO, because you are draining and returning to the same side of the heart, which is the right heart, you have to ensure both cannula tip are away from each other, about 7 to 10 centimeters distance. Otherwise, you might have what they call recirculation. If you have the drainage and the return cannula very close to each other, your return will be drained by the drainage cannula. So the drainage cannula should drain deoxygenated blood from the right atrium. It should not drain oxygenated blood from the return cannula. And that's something you can avoid first by checking the tip of the cannula, making sure that they are 7 to 10 centimeters apart, and also by looking at the jet of the return, which has to be directed towards the tricuspid valve, the right heart, and not towards the IVC, where the drainage cannula is. Another pitfall, another troubleshooting is a drainage cannula position in the liver. In the IVC, it should be clear from the hepatic vein, otherwise it can obstruct the flow of the hepatic vein. And also, obviously, LV distension. LV distension, thrombosis, it can happen on peripheral V ECMO, and echo is fundamental in assessing and visualizing thrombi, the LV dimensions, and also looking at Doppler parameters for increasing LV EDP. Worsening mitral regurg, diastolic mitral regurg, retrograde systolic pulmonary venous flow reversal, even closure of the aortic valve. When the aortic valve closes all the time, you know that the LV EDP is very high. And here you have the example of an aortic valve that is closed throughout the cardiac cycle because the LV EDP is very high. And after septostomy and offloading, the aortic valve is back to opening with every beat. And that's what you want to see to maintain the integrity of the aortic valve and also ensure that this LV is being offloaded with ejection. And another interesting issue which can happen on peripheral V ECMO is when the heart starts ejecting while the lung is poor, while the patient have bad lungs, consolidated lungs, and heart is ejecting. What can happen, the ECMO will provide flow to the lower half of the body, while the heart will eject deoxygenated blood because of bad lungs. And this will cause what we call Harlequin syndrome, which is the north-south syndrome, where you have deoxygenated blood at the upper half of the body and oxygenated blood at the lower half of the body. And this is really dangerous because if you miss the diagnosis of differential hypoxia, you might develop brain ischemia. Your patient might develop brain ischemia. You want to have oxygenated blood reaching the carotids, which is fundamental. And that's something you could see here by this aortography, that there is a competition between the native ejection across the aorta, which is the heart ejecting blood. In this case, it was deoxygenated blood because the lungs are bad, and the ECMO returning in the descending aorta. And that's why you should always have the arterial line on the right hand. You should always have the SATS probe on the right hand. Patients on peripheral ECMO should have NIRS, or near infrared spectroscopy. These tissue oximetry pads applied on the upper half and the lower half of the body to look for any differential changes in tissue hypoxia. So you should have very high index of suspicion. And when you identify that, you have to immediately manage it, whether by optimizing ventilation, bronchoscopy, recruit the lungs, giving diuretics, increasing ECMO flows. Sometimes you need to give inotropes to reduce the contractility and reduce the native cardiac output. Or if nothing works, and most of the case, these medical measures don't work, you need to reconfigure the circuit and add an extra venous return cannula. So you reconfigure the ECMO from VA to V-AV. So you're adding an extra cannula on the venous side as a return cannula. So you're combining VA and VV together. But this is not always the answer, as in this case, we identified a patient who had Harlequin syndrome, but didn't get better, he got worse, when we added a venous cannula on the return side. And that's because the Harlequin was induced by right heart failure. And when we reconfigure the circuit and put this additional cannula on the drainage side, the patient improved immediately. So the point here that I want to make is that every patient is different, and echo will enable you to phenotype the patient and give the proper treatment and never forget the right ventricle. And finally, weaning. Echo is fundamental in managing patients at the end of their ECMO run, identifying the weaning criteria. These are published criteria for many years ago. This is, and there are different weaning protocols in different institutions. Some institutions wean the ECMO flow by 1/3, and some institutions go a bit slower by 0.5 to 1 liter reductions of flow, combining echocardiography with pulmonary artery catheter and the clinical parameters. And in our paper, we discussed the distinction between readiness to wean and readiness to explant, because they are different, particularly in borderline patients. Some patients might be ready to wean, but when you wean them, they fail. And that's why you need to have more robust thresholds, higher thresholds for VTI. You can notice here for ECMO that the VTI for readiness to wean was 9 centimeter, while for readiness to explant was more than 10 centimeter. And this applies to all other parameters. So when you have a borderline patient, you need to make sure that the patient are on the lowest flow possible, achieving a higher thresholds for cutoffs. But also patients with borderline RV, because we know that many patients on VA ECMO fail the weaning trial, not because of left ventricular failure, but because of right ventricular failure. And that's why we recently investigated a protocol which is used more among pediatric population, which is PCRTO, or pump-controlled retrograde trial-off, which basically means that you are using the ECMO pump, to achieve a left to right shunt. Usually when you stop ECMO, you stop the pump at 0. or reduce it to 1 liter. But at 1 liter, you are still going right to left. So you have not overloaded the right heart enough. And even at 0, you have not overloaded the right heart enough. But with this retrograde trial off, you are allowing the pump to go minus. Of course, that requires perfusionists at the bedside, and this causes left to right shunt to overload the right heart. And this will ensure that the patient will succeed ECMO weaning. And we found that it changed the management and the decision in 78.5% of our patient cohort compared to the traditional VA ECMO weaning. And finally, don't forget the RV. RV is a complex structure. 2D echo is not enough. You have to use Doppler. You have to look for any signs of restrictive right ventricular physiology and also going beyond the heart. I mentioned in the beginning that I call it now echography because you have to even go beyond the chest cavity, looking at the liver, the hepatic vein, portal vein. To me, this is the right ventricular preload. And you could quantify right ventricular preload by using Doppler assessment of flow across the hepatic, portal, and renal veins. And finally, just to share with you, a few years ago, we published this book with a group of colleagues, and it has a chapter on echo in short-term mechanical circulatory support, which I hope will be useful. And finally, we also published last year this work, particularly covering Doppler hemodynamics, because I truly believe that Doppler is widely available and it's underutilized. Many people now learning echo are fascinated by structural echo, which is great, but we should always empower functional echo. And I mean by that Doppler. So I hope that will give you some more information. And finally, this is the latest European guidelines from the EACVI, ACVC, and the ACTA, which discusses in depth the use of echography, as I said, in cardiovascular emergency and critical care. My final word here, I hope I was able to show you that echography is central in ECMO and short-term MCS decision-making. We need to remember to choose the right modality, always remember the role of the right heart. Echocardiography is not enough. It is multimodal assessment of the heart, the lungs, the systemic veins. I call it the pyramid of hemodynamic ultrasound. So heart is not enough. We need to look at the lungs and we need to look at the systemic veins, hepatic, portal, renal. If you have time, you should also look at the femoral vein. And finally, echo in ECMO and MCS is not basic echo. So this is a very complex specialist echo. If you want to learn it, you should first learn echocardiography, the foundations of echocardiography, and then we'll be a step further down after learning how to manage ECMO and mechanical circulatory support. And then you will be able to combine both your expertise in echo and short-term devices to practice echo safely in these patients. Thank you very much for your attention and happy to take your questions.
Thank you, Dr. Hatim, for the excellent enlightening lecture. Allow me to have the first two questions. So my question, based on extensive experience, is there any single most important echo finding that influenced the choice or the configuration of the mechanical circulatory support?
Well, it's difficult to say single because we don't rely on a single parameter, but certainly VTI itself is it's a very important parameter, and it's something that you cannot miss. But I cannot think of a single parameter which can influence the decision making. Echo decision making in MCS is complex, so it requires multi-parametric assessment. Certainly, and not only echo, by the way, also pulmonary artery catheter. We use it routinely in these patients. I know that some centers use echo alone, but in my experience, I use both because the decision making in these patients is difficult. And that's why I cannot think of a single parameter to rely only on it. It has to be a multi-parametric approach.
So you actually brought my second question. So if there is conflict information between the invasive hemodynamic and the echo, is there a specific situation and what you do in this situation?
Of course. Yeah, absolutely. And that's why we use both, because we know in some scenarios, one of them might be better than the other. We know that patients with at the extremes of cardiac output, the right heart catheter does not work. Patients with severe hypothermia, thermodilution does not work. We know that thermodilution does not work on ECMO. So every scenario is different. That's why we need to use both. Doppler is very sensitive at the extremes of cardiac output. Like if you have very low cardiac index, if cardiac index is less than 2 or 1.5, PA catheter will not give you reliable data, while echo will give you. Particularly shunts. If you have shunts, intracardiac shunts, you can be misled by the numbers you obtain from the right heart catheter, while echo will show you the shunts. You can even quantify the shunts. While on the other hand, the gold standard for um, continuous hemodynamic monitoring of pulmonary artery pressures, the wedge pressure is the right heart catheter. And that's why we use both. Echo itself, because when we say echo, we use echo intermittently. We don't use echo as a continuous hemodynamic monitoring. And that's one of the main limitations. Until we reach a time where we have a continuous small TOE probe to provide continuous hemodynamic monitoring, it will remain a major limitation for echo, that it gives a snapshot of hemodynamics, which is the major strength of the right heart catheter. I hope I answered your question.
Yes, because it's almost similar to my understanding. So are we relying on the transthoracic echo all the time, or I have to do transesophageal if the view is clear? Because I figure out like some patient, they will not show a lot of finding. And then when we do the TE, it's give us a completely different picture, especially if there is any thrombus or any situation where we're going to transplant.
Sure. Are you talking before ECMO or on ECMO?
While the patient on ECMO.
Yeah, this is important because, on ECMO patients, on VA ECMO patients are usually anticoagulated. So we have to be very careful about uh, repeatedly doing transesophageal echo. We do lots of transesophageal echo, but it is not without risk. So if the patient has good windows, of course, transthoracic echo would be reasonably good. I would only do transesophageal echo if I don't have good windows, mainly because of the risk of bleeding in these patients. But yeah, I think we should always keep both available with us. Some questions are not answered only with TTE. Sometimes it is better to use TTE. If you have a prosthetic valve, for example, you might not have adequate images of the heart with TOE. But I think we use both interchangeably. And I know colleagues in our institutions who rely solely on TTE. They even use contrast to improve visualization of LV cavity to get away without using transesophageal echo. But if you work in a cardiothoracic center, transesophageal echo is very important. If you have patient on central via ECMO open chest, there is no way. You have to do transesophageal echo.
Okay, thank you. There is one question from the audience. Can you please once again explain the calculation of ejection fraction based on VTI?
You mean stroke volume? Sure.
She wrote, I read it as it's written, but yes,
Sure.
I think she meant cardiac output.
Absolutely. I think, yeah, the equation is, the assumption is that the LVOT is a cylinder. So if we assume that the LVOT is a cylinder, see, if I know the height of the cylinder and the area of the cylinder, then I can calculate the volume of the cylinder. لأن حاصل ضرب الهايت والاريا بيديني الفوليوم. فthe height هو ال VTI. If the LVOT itself is a cylinder, طول ال LVOT هو ال VTI, والarea is measured from the long axis view. So if you obtain both, you multiply them, you get the volume, which is the stroke volume. And لما تضرب the stroke volume على heart rate, you get the cardiac output. And when you divide the cardiac output by body surface area, you get the cardiac index. The VTI is the dynamic number. هو الرقم اللي هيتغير. It is the number that will change continuously. And this is the number that you need to repeatedly measure. But the area will never change in the same patient. So if you want to measure the area, and I didn't discuss that in detail because I was only mainly talking about MCS. If you want to measure the area, don't repeat it in the same patient, because the equation of measuring the area start by measuring the diameter and then squaring the number to become area. So if you keep re-measuring the diameter, if there is any error in measurement, the error will be squared. This is one of the big pitfalls. And also the number will never change. So what I do in practice, I don't measure the area. I roughly use I know that most people, not everyone, but most people have a diameter of LVOT of about 2 centimeters. Remember this number. And diameter of 2 centimeter will give you an area of 3.14 square centimeters. This is roughly the average area of the LVOT in many people. Some people have bigger areas, some people have smaller areas, but this is how I do it. I only measure the VTI. Yani, let's say you have a VTI of 10. Let's do the calculation together, and I hope the one asked the question will do it with me, so it makes sense. So let's say we have a VTI of 10 centimeter, okay? So I will have 10, and I multiplied أضربه by 3.14, which is the area, okay? That will give you a stroke volume of 31.4 milliliters. And if you multiply it by heart rate, let's say the heart rate is 100, that will give you a cardiac output of 3.140. 3.140. If you want the cardiac index, you divide it by body surface area. خلينا نقول 1.6, 1.7. That will give you 1.8 cardiac index. This is very simple and very easy at the bedside. So I don't routinely measure the area. One thing to keep in mind before you do this, if you see a low VTI, you have to have experience in visualizing the LVOT size, because some people have bigger VTI than others. So don't miss completely the size of the VTI of the area, even if you don't measure it. Why I'm saying that? Because some people have a larger LVOT, and if you have a larger VOT, that can compensate for a smaller VTI achieving the same stroke volume, if that makes sense. See, if I have a VTI of 12 or 10, and I have a diameter of 3 or area of 4, you will achieve a good stroke volume. So you cannot only jump into the conclusion that the cardiac output is low based on the VTI alone, if you see what I mean. At least visually assess the area with your eye. I hope I explained it clearly to everyone.
Yes, it's clear. Actually, we have been doing this, even me. I'm just taking the number
Great.
2 and following the trend. So the other question is, I could understand the importance of total isovolumetric time.
You opened okay. So أنا طبعا I only touched upon it because it can be a complete lecture on its own. The total isovolumetric time is a parameter that is specific to the chamber. The total isovolumetric time on the left, and there is TIVT on the right. What I wanted to say is, if you have a low LVOT VTI, you are not sure the problem is in the left heart or right heart. So if I measure the TIVT on the left heart and I see it normal, I am sure the problem فين? On the right. There is nothing else. And that's important. But if it's abnormal on the left, I know the problem is on the left. And this is important for deciding mechanical support. I want to know I need a device for the right, device for the left. Patients with isolated RV failure, they need RVAD or Protec, Impella RP, which was used previously. But that is what I wanted to say.
The third question is, if your time allow, how to calculate cardiac output in patient with Impella?
Very good question. So there are a few things. RVOT VTI can be very useful, very helpful, because the LVOT VTI itself will be affected by the presence of the device across the aortic valve and the LVOT. So you can use RVOT VTI. The same can be applied for durable LVAD or Impella. The problem with RVOT VTI is that we don't know what is the normal range. There is no validated cutoff for RVOT VTI. The only thing we know is that less than 10 centimeters is bad, prognostically bad. So if you find it more than 10 is good. If it's less than 10 is bad. But this is what we do. But also experimentally, we looked at the LVOT-VTI. If the native contractility is improving while reducing the impeller flow, the LVOT-VTI should increase. And this is another thing which can help you weaning the impeller, but this is not validated. We looked at it in several patients, and this is a parameter which can help, and it makes sense because it's more physiologic. When you reduce the impeller flows, if the heart is improving, you should see improvement in the LVOT-VTI.
I have the last question. If Dr. Abdurrahman and Ahmed, they don't have any further. So it's also related to the right side. So in isolated RV failure with the ECMO support, any ECMO parameter predicts success of weaning other than what we mentioned?
طبعا there are many parameters. طبعا في traditional parameters, but recently strain imaging, particularly RV, RV strain is was found to be a strong predictor of ECMO success, of weaning success, particularly the RV free wall strain. On top of the traditional RV parameters. So this is my answer basically. So all the echo parameters we know about the RV, but on top of that, the strain assessment, particularly the RV free wall strain.
Thank you so much for your time. Dr. Abdurrahman, do you have any question?
Thank you دكتور حاتم دكتور أشواق.
صديقي العزيز.
أهلا كيف حالك؟
الحمد لله.
It's for the excellent and highly informative talk صراحة in MCS and Echo. Super presented, and I would to add something that would be, and I think we agree all of us about it. The Echo and the Swan guns is not alternative for each other. It's complementary for both. So if you use the Echo, that mean tell us why the heart, how its heart looks. It looks like Sam, you should know by the echo. So tell us the heart looks like and why it's failing now. The Swan gas, it's in the different side. It will tell us the continuous, how to the circulation performing and how can we give it and responding to the treatment. So most of the time, I know some institution in our country, they use echo dependent totally, and the other is Swan guns. So I think we should combine both to complement for our patient.
Absolutely. I totally agree, Abdurrahman. Thank you very much.
Thank you.
Thank you so much, Dr. Hatim, for your time and for the excellent comprehensive presentation. Appreciated honestly your time and even your knowledge. Inshallah, we will do further lecture in the future. Thank you so much.
Thank you very much. بالتوفيق إن شاء الله. شكرا. السلام عليكم.
السلام ورحمة الله وبركاته.
عليكم السلام.